Good morning, everyone, and thank you for joining us for Winship Grand Rounds this morning. As a reminder, if you're an Emory University or healthcare employee and you would like to receive CME credit for your attendance today, the access code is 306409 and can be found in the chat feature at the bottom of your screen. Otherwise, if you have issues, please send Jeniel Taylor an email or drop a note via the chat feature. This morning, it gives me a great pleasure to introduce Dr. Lisa Licitra, who is a very well-known international leader in the treatment of head and neck cancers. She is currently the Director of Medical Oncology, Head and Neck Cancer Department at the Fondazione IRCCS Istituto Nazionale dei Tumori, the foremost public hospital and government-designated national cancer center for treatment and research in Milan, Italy, and is associate professor at the University of Milan, teaching oncology in the Faculty of Medicine, and as well as the Masters of Biotechnology, Psycho-Oncology, Pharmacology, International Medical Oncology, and ENT specialties. So you can see her multi-talented specialties there. Dr. Lisa has been involved in clinical and translational research in head and neck oncology as long as I have been doing head and neck cancer for over 25 years. Her multidisciplinary approach has changed our standard of care, has created and facilitated new personalized treatments and models for other cancer types. She has been a scientific coordinator for the Alliance Against Cancer, which is the largest national oncology network created by the Ministry of Health. Dr. Licitra is also actively involved in international education and research programs for head and neck cancer through societies such as the European Head and Neck Cancer Society, for which she is a co-founder and member, EORTC, the European Organization for Research and Treatment of Cancer, whom she was vice president, as well as ESTRO, European Society of Radiation Oncology. She's an honorary member, and ESMO, European Society of Medical Oncology, head and neck faculty and member of Guidelines Committee. She's a member of the Clinical Editorial Board of Oral Oncology, as well as the Union for International Cancer Control, TNM classification of malignant tumors staging committee. Dr. Licitra has authored more than 23 book chapters, 406 articles in peer-reviewed journals. She has an H-index of 73. And without going further and further, because I can continue speaking, and I'm not sure you want me to be the main speaker here, I'm very glad that she accepted our invitation. And I hope that in the near future, we will see her personally in Atlanta. Lisa, it's a pleasure to have you on, and we'll all look forward to your talk. And thank you.
Thank you. Thank you, Nabil. I hope you can hear me well. Okay, thank you. So thank you for the nice presentation. Actually, I'm a medical oncologist dealing with head and neck cancer since many years. And basically, by taking care about head and neck cancer patients, I had the opportunity to study and to go through different disciplines. And so this is the reason of my multidisciplinary attitude, because what I have understood is that drugs only cannot really cure this cancer. And this is still the case in this moment. So I will start by sharing my screen. Okay, you should see it in full screen.
Yes, we see
it. Okay, thank you very much. So when Nabil asked me to provide you with some reflections on head and neck, I was really very happy to do this in terms of looking at the data and basically of looking at what we did at my institution, you see, Istituto Nazionale dei Tumori, where I'm leading a team that is a clinical team, of course, but of course we work in a multidisciplinary way together with basic scientists, but more than basic scientists, I would say interested translational scientists in head and neck, which is not always easy to have. So I will try to walk you through our data, trying to and also with the end in the end of this discussion, I really need your input in asking you. I will ask you in which way you would see the development of this initial results. So we will start with the introduction to omics. I don't think I have to tell you which why gene expression. And the omics that we do have today, it's we have genomics and we have epigenomics and transcriptomics, and here there is a list of the material which is analyzed, the methodologies which are used today, and the type of information that we may get from this analysis. Basically, we do have a problem with head and neck cancer because we know that in head and neck cancer, there are many mutations. Unfortunately, the mutations that has been observed in head and neck cancer are mainly on oncosuppressors, and we know how difficult it is to tackle oncosuppressor genes. And so the reason why we were interested in developing something which was beside, I would say, mutational analysis, which took all the fields in non-head and neck oncology, it's exactly because we understood from the very beginning that we would not have had the same opportunities to treat our patients based on mutational analysis. So we do have genomics, transcriptomics, proteomics, and metabolomics. Now, with that, we were much more interested in transcriptomic and in genomic. We are like starting some activity with the proteomics, and we have no experience with metabolomic. Of course, then there is the big question about, even if in the moment I do have all this information, I will have to take this information together and to extract all the knowledge that I might be possible to extract from this, I would say, big data analysis somehow, because we know that the data, the bits that are forming this information are big. And so here we are starting thinking, and we are starting to employ somehow some processes like deep learning or advanced models for understanding what's behind a certain genomic or transcriptomic analysis. So we started, as I told you, we started many years ago, and we started with the gene-by-gene analysis, with a gene-by-gene approach. And at that time, it was very important to look at TP53 and HPV status. And basically, we were, by doing this analysis in an Italian trial, which treated patients with radiation or chemorad. It was a small trial which was published in 2009, as you see here. We were able to see that, for example, patients with HPV positive tumors, they do have a wild type TP53. And so this was our approach at that time. We were also looking at the prognosis of these patients. Of course, some of these patients do have HPV positivity with TP53 mutated gene. And of course, the prognosis of these patients harboring HPV positive tumors as well as TP53 mutations were few, but their prognosis was worse than the HPV positive TP53 wild type. And then we were very interested in trying to understand who were the patients that responded so well to induction chemotherapy. You know that we did a big study, national study on oral cavity cancer, where we did for example, where we did PF in oral cavity cancers. It was a randomized trial. Unfortunately, it was a negative trial. Induction chemotherapy was not associated with a better outcome of our patients, as opposed to standard of care, which was surgery followed by radiation or chemorad, chemorad. The patients we saw in that arm, in that cohort, patients that had pathological complete response. So we wanted to understand whether TP53 could help us in understanding whether a patient could have a response to induction chemotherapy. At the end of a long story, and the same reasoning was applied to intestinal type adenocarcinoma. This is a very rare tumor that you probably, that we see really rarely. We saw that patients with wild type T53 were much more, significantly more prone to develop a pathological complete response. It's important that we know who are the patients that develop a pathological complete response, because we know that those patients are those that are really benefiting in the long term of chemotherapy. And if you think about what happens today when we use immunotherapy together with the chemotherapy in the preoperative setting, it might be very important to look at who are those patients that may develop such a huge response. In addition, I would say that since we are using induction chemotherapy for organ preservation, and we know that response is the criteria with which we prescribe after having this response radiation, and we avoid surgery, it might be very important to use biology instead of testing chemosensitivity in vivo, to understand who are the patients that might benefit from radiotherapy as compared to surgery. Then times went by at the time, and so we were interested in looking at EGFR, because at the time cetuximab came to our in the field, and we looked at EGFR copy number as a predictive biomarker, and this was studied both in also in the colon cancer as well as in the extreme trial, which was the first trial that in first line in the recurrent metastatic setting, that showed that platinum 5-FU plus cetuximab was better than platinum and 5-FU. By the way, this EGFR copy number, yes, it was predictive so and so, and it was not considered as like a good biomarker to understand whether cetuximab a good predictive biomarker when we speak about cetuximab. We were also interested in looking at whether these EGFR family receptors were involved in a proliferation of squamous cell carcinoma induced by wound healing fluids of head and neck cancer patients. So what we did, we studied different cancer cells, and we, of course, head and neck cancer cells, and in vitro we stimulated those cancer cells with wound healing fluids, and we were able that those cancer cells were significantly pushed into the proliferation phase, and they were using EGFR family receptors, suggesting that EGFR is really it's an important part of the biology of head and neck cancer. At that time, we were also interested, again, a gene by gene approach, or some gene approach, not a single gene, but here in this work, we looked at, for example, in the HPV positive, and within the HPV positive, the PI3K mutations. And at that time, we were able to see that patients with HPV positivity were less frequently PI3K mutated. I think it was the first time that something like this was observed. And we looked at P53 in these subgroups as well as cyclin D1. And we were like exploring some subgroups within oropharyngeal cancer beside the within the HPV positive and extra HPV positive. So let's go to the gene expression in head and neck. So what I learned from the people that are working in the bioinformaticians and biologists that are working in my institution, it's basically you can do a gene expression meta-analysis, similarly to what we are used to see in the clinic, where when we are looking at the data that are meta-analyzed, for example, the randomized trials can be meta-analyzed, and you have some results by putting those randomized trials together. The same can be done by biologists according to bioinformatical studies. And here, what it has been done, Loris De Cecco was very instrumental in that. He's still working with us. And he looked at a gene expression meta-analysis of all the publicly available data sets that were published at the time. So you see here a list of the data sets that were published at the time. He looked at these data sets, and he developed a 172 gene signature based on literature data that were able to separate head and neck cancer patients coming from these data sets publicly available in two groups, the high risk and the low risk. Of course, we were very interested when we saw this data. We were like, for sure, and this was 10 years ago, we were really looking at these suggestions to see whether we might be able to understand better the biology of the disease. What he did, by doing a very similar type of analysis, because when the literature is full of this gene expression analysis data, and every day you get a new signature somehow. What he did at that time, and here you see this is a paper that was published, and he puts together again many patients from this meta-analysis, and he was able to select I would say to separate six clusters, sorry, cluster 1, cluster 2, 3, 4, and 5. And he was trying to describe these clusters. By the way, this was not the first time it was done. You remember the paper by Christine Chang that was published in Clinical Cancer Research some years ago, and she was able to find 4 clusters. Here, Loris looked at was able to find separated 6 clusters, and here you have the functional pathways that are reported in the different clusters by the oncosignatures, previously reported subtypes. So some of them are recapitulated in previous work, clinical pathological parameters, outcome, previously reported classifiers, and final designation. So if you look at cluster 6, for example, I will try to focus on some of them. Cluster 6, this is the immune response. This is the immune positive, I would say. This is the immune, what Loris said is it's immune reactive. And we will see this cluster at work in other work. In other paper that I will show you. Then there is this cluster 2, which is always very bad, cell motility, EMT, angiogenesis, with a lot of, for example, you see TGF-beta. Then you see here this EGFR, the oncosignator, which is associated with cluster 3 is the EGFR. And then you have the HPV cluster. But here again, you see that the notion that we got from this analysis is that, of course, heterogeneity of this biology is very high, and we would have to take into account this heterogeneity probably to tackle these biologies in different ways. What we did is, for example, an analysis of a windows of opportunity trial where cetuximab and afatinib were given 2-3 weeks before surgery, and it was Loris and my group were able to see that there was like an anti-correlation between cetuximab response and immune score. The higher the immune score is, the less probability of having a cetuximab response. And here you see it's quite similar for both drugs. So it's important that we consider those clusters in the context of the biology of the tumor. And of course, those studies were done in the era of pre-immunotherapy, although by these results, we can really understand that there might be interesting correlation or anti-correlation that we have to take into account when we are selecting drugs. Here you have another gene expression subtype to outcome and treatment response in patients with recurrent metastatic head and neck cancer. Those patients were treated in a phase 4 study, in an Italian study. Those patients were treated with nivolumab in a second line. And here you see that the cluster, you remember the cluster 6 that I was showing you before, when together with the other clusters, you see that cluster 6 was able to recapitulate good response to immunotherapy in this phase 4 study. So we know that there are other gene signatures, for example, interferon gamma signatures with 8 to 6 genes, but here you have this cluster 6 score that performed, I would say, very interestingly when it comes to response to immunotherapy. Also, I think that the literature is very important, that we look at the literature, for example, of the pan-squamous cancers. And here, to me, this is like a paper which is always really attracting my interest very much, because here you have all the squamous cancers that were analyzed by DNA methylation, mRNA, copy number, mutation, protein array, and other pathways, for example. Here you see the different diseases. So you see cervical cancer, you see esophageal cancer, and here I do have a list of what has been observed by looking at this cancer in the same way. But clearly what you see here, that despite we are speaking about pan-squamous or with the same histology, if you look here, for example, of the immune to the immune-related alterations, you really see that among the different cancers, for example, head and neck and lung cancer are very different. So to me, it's very important that we consider head and neck cancer completely different. The biology is completely different from all the other one, and this should be taken into account. And also gene expression analysis is a way with which we may find these differences. And also this puts the question about when we for example consider to use a drug because it has had a good results in lung cancer, and then we may use it in head and neck cancer. It might be not a good idea not to consider this data and to overlook the opportunities that such studies may offer. And so, for example, you see here, these are the HPV. For example, there are differences between the HPV positive cervical cancer as opposed to the HPV positive head and neck cancer. I don't know what's happened. Okay. Now, we also, we did, for example, an evaluation of gene expression analysis of HPV positive patients. I will speak of these results later, but this is useful for me at this point to tell you that we compare these three gene signatures that we found on more than 500 patients. As you see here, we found three signatures. The cluster 3, the cluster 2, and the cluster 1 among the HPV oropharyngeal cancer. When we compared these clusters that were found in our series, this is a personal series, we compared this with the cervical cancers, the squamous cervical cancer, the HPV positive patients. These are data from the literature. These are not personal data. You see here also HPV positive cervical cancer has a low and intermediate and high risk, class 3 clusters, and the same happens with oropharyngeal cancer. These are different clusters, but there are correlations. The intermediate cluster 2 of cervical cancer is very similar to the intermediate cluster 3, as well as the high cluster 2 with high cluster 1. So in practice, what we are seeing is that although these are different diseases, they might share similar gene expressions when it comes to risk features. I don't know whether among you there are radiation oncologists. Of course, in a disease that can be cured by radiation or surgery, we were very interested to follow the literature about radiosensitivity, because this is something that might really have an impact on decision making. So this is the radiosensitivity index, which it's a gene expression that predicts radiosensitivity. It's a model based on radiosensitivity from the expression of 10 hub genes. The list of these 10 hub genes is provided here, and it has been validated in several papers, as you see here, and the main paper was main papers were on cancer research on the Red Journal, as well as on clinical cancer research. So basically, these authors were able to define at least 10 genes that, taken together, might predict, according to this model, might predict radiosensitivity. They elaborated a little bit this radiosensitivity index. This is a very complex mathematical models that radiation oncologist knows very well. I'm not a radiation oncologist, but basically they put together the radiosensitivity index, meaning considering the biology of this of each patient, and it was it can be this biology can be associated with the dose and the fractionation that the patients are getting. Here, if you look at this picture, you see that, for example, head and neck cancer patients, they normally receive 70 grays. And here you see that the radiosensitivity index is really this is the common dose. So the dose is fixed, but their biology is very different. And so you see here that there is a very high range of GARD, which is the gene associated radiation dose, which is to repeat myself, is a multiplication of the radiosensitivity index with the dose of radiation at each point, for each patient. You can do also silico trial by using these models, which has been done in this paper, which is on the med preprint, and we are working on that together with Torres Roca and his group. This paper that you will see, according to this model, they were able to, by using this radiosensitivity index, by using GARD, to predict who the patients who may benefit from a de-escalation, according the HPV positive patients who may benefit from the de-escalation of radiation. When you do not use the de-escalation 60 versus 70, which is the head and neck 005 study, of course, we all know that this study was negative. So interestingly, to say that the probability of being selected in a good way to be de-escalated, it's in 20% of the patients. So we might assume that those trials, that head and neck 005 trial, was not positive because of the 20% of the patients that, despite their that were not de-escalated because they were entering the arm. So this is the study that I wanted to show you in the before about HPV positive patients. This is a study that was done on, you see here, on 250 patients. This was a big study. We started again, Loris De Cecco started again from this meta-gene analysis and he was able in HPV positive patients to sort out 3 clusters. I would say a good one, an intermediate one, and a bad one. When we validated this on 250 patients, and these were from a big European study, in a Horizon 2020 European study that collects HPV positive patients and all the clinically annotated, they were heavily clinically annotated with more than 150 clinical variables, which are much more than what you get from the TCGA or from the gene expression analysis data that you can get from the literature. For example, here you see that we were able to separate in terms of overall survival based on gene expression analysis, and here you see how well it differentiated. This is the same series that was evaluated according to the staging system, and here you see how some of the patients that are considered high risk or for stage 4A according to the 7th edition may entering the stage, the 8th staging system, and they may they can be separated biologically into low risk, high risk, and intermediate. So we worked also together with other groups in that direction. So another group was looking at on more than, you see, 800 patients, and they were able to, and we provided our data to this group, of course. They were looking at the immune-rich, a mixed and immune desert among HPV positive patients. And you see, by applying this model to the prediction model to the probability of overall survival, here you see that the gene signature together with the clinical data are the best signature. So what we are learning in that is that these gene signatures are very helpful in defining the prognosis of the patients, and sometimes some of them may benefit from the addition of clinical data. Basically, clinical data will be forever used to make the decision making, and here we have the opportunity to add to this clinical data also gene signatures results. We also were interested in nasopharyngeal cancer. This is not a paper from our group, but here you for sure you know this randomized clinical trial in recurrent metastatic NPC patients with tislelizumab. This is immunotherapy, and here you see that the only prediction in NPC was on a gene signature, which was an activated dendritic cell gene signature, which was associated with tislelizumab chemotherapy FS benefit. And here you see the cold and the hot tumors, how they were separating the patients benefiting from the addition of immunotherapy. By the way, nothing else was working in that regard. So we were interested in looking at gene expression in endemic NPC and to compare them with the NPC in the non-endemic area. You know that Europe, as well as the Mediterranean area, is a non-endemic area for NPC. And also what we are doing is that we are taking for granted the data. For sure, we have to take those data from Asia, for example, and we are looking at we are treating our NPC patients according to the data that are developed and are studies that are done mainly in Asia. So what we do have here is that the gene expression in endemic NPC, according to the meta-gene analysis on 300, more than 300 NPC, 4 clusters were found. These are ABV-related NPC patients, and here you have the clusters that were defined according to this meta-gene analysis based on data from the literature, and you see how different these genes, these clusters, differs from the normal tissue. Here you have the normal tissue, and here you start seeing how like far are these clusters from the normal tissues. I think this is an interesting way in which we may think about the biology of cancer. What is the prognostic value of these 4 NPC gene expression subtypes? Here again from the literature. So we looked at the outcome of these patients based on these clusters, and here you have 4 clusters. Probably there is this cluster 3 again, which is very poor performing in NPC. We did here in Italy. We did a validation on another gene, on another series. Again, this was a Asian series of patients, and here you see that the cluster 3 was performing less well as expected. We do have also we tried to correlate these 4 NPC subtypes together with the clusters that we have and the immunoscore, finding similar to what we have found previously in oropharynx cancer, that the immune properties were different among the different subtypes. What can also be done with this gene expression analysis, you can also predict the chemosensitivity, and this is something that was done in the endemic NPC, on the endemic NPC data. And here you see that, for example, cluster 3, which was the worst one, seemed showed greater, cluster 3 showed greater chemosensitivity than the others. So suggesting that the cluster 3 can be, should be aggressively treated, or there are biological reasons to think that cluster 3 may benefit from an aggressive chemo approach. What we did on top of it is to look at our NPC patients. Our means in-house, those patients treated in my institution, and there were 47 non-endemic area NPC, which was profiled for gene expression. And here you see what happened is that in practice, we didn't find the cluster 4. So at the end, in NPC in the endemic area are made of 4 biological clusters, while we didn't find the cluster number 4. Which was the exhausted EBV replication has this exhausted pathway. We don't know whether this is due to the fact that we do have that our series is still with few patients, but we are continuing this work to try to understand whether there are biological differences among endemic and non-endemic NPC patients. I will skip this. We looked at inflammatory signature to understand the first whether those patients, some claimed that this inflammatory gene expression analysis could be related to the first-line cetuximab to the extreme in patients treated with recurrent metastatic head and neck cancer. Of course, these were out of trials, but if you look at this data, some of these signatures could predict the outcome of patients in first line with cetuximab and chemotherapy. And here you see the probability of having a CR or a stable disease or a progressive disease. So based on this data, what we were interested in is to build an international multi-source, multi-omic database, because here we are collecting a lot of data, and what we would like to do is to really to understand how to put them together. And so this is a big study that we did that is concluded in we need to decide and to look at for models for the personalization. And here the question was, are we able through gene signature analysis to beat somehow the TNM? How can we improve the prognostic prediction in head and neck patients? And of course, with the idea to maximize the therapeutic results and minimizing negative impacts. And so these are the data that we were collecting: gene expression, imaging, radiomic and clinical data, as well as pathological data, and we put them together. This is the consortium, and this is the database that we do have in-house. And I must say that some researchers, investigators also from US are asking us to validate their signature, their data, because this is a sort of big TCGA, I would say, clinically annotated TCGA. Here you have the data. We do have many clinical data, radiomic and transcriptomic, and here we put them into comparison with the data that are already available, such as TCGA. These are some of the results that we were able to look at, to provide together with people from the consortium, of course. And here we have radiomic data on CT, but also radiomic data on MRI. All they were prognostic radiomic features to predict the outcome of the patients. And here we do have radiomic versus GE, and you see that the radiomic signature seems to to perform good when it comes to the evaluation of the 6 clusters that we were speaking before. You all know about the idea of putting radiomic and genomic or the radiogenomic or the radiomic model. And here you see our first experiment. What we have seen is that probably when genomic are very good in predicting outcome. When we go for radiomic alone, it's less good. By putting genomic and radiomic together, we are much able to provide differential results in terms of overall survival. Which are the difficulties of merging database? And here we do have another, this is an ongoing study, which will be concluded very soon because we finished it. So the idea was to put together all this data in Europe, and here it's again another consortium. And we put together many data sets, but here the question is how to provide this, how to combine all this data, because they are these results are done in different laboratories with different methods and so on. And so there was we went through a huge effort to harmonize this data in order to be able to look at this data all together. So clinical harmonization, I will not go through that, but this is a big issue that will takes a lot of time in the past in order to go for this. But the important way in which we did it, data mapping, standardization of terminologies, structuring data integration, and this is what it has been done. The only important thing that I have to tell you, and this is might be useful for the whole community at this point, we do have an ontology for integrative research in head and neck cancer, which has been published. So everyone who wants or needs to have this ontology in order to put together data can, of course, take this as an inspiration or as a work done that we did in the past. We do have the main problem, and this is the question that I would like to discuss with you. Is the main problem is the acceptability of this data, and the SuperTreat project was really within the project there was like the question to which extent these data are acceptable. As a biomarker of prognosis, as a biomarker of prediction. So, for example, we worked on that idea, assuming an equivalence between surgery and radiation. Would you accept the following schema based on tumor biology? We know that, for example, in early stage, a T2 or T1 or T2 patients can be treated with radiation or surgery. So, in the moment you get a radiosensitivity, good radiosensitivity, you will get radiation. If you are not radiosensitive, you might get surgery. So assuming that this is acceptable, what would you do? So would you rely on a decision support system telling you that if the patient is radiosensitive, the patient should receive radiotherapy? On the contrary, if not radiosensitive, the patient should receive surgery. And here the question is on how to present this data, both to the clinicians as well as to the patients. And we are still struggling with the problem on how to I would say, consider and how to import this knowledge, that is gene signature knowledge, somehow into the evidence-based mechanisms, because at this point we are really they are really not considered, although we do have a lot of data validating this approach. And with that, I would really conclude my presentation by asking you, or like putting as a provocation somehow, how do we need to, in which way do we need to validate these gene signatures? If you think about breast cancer, for example, there are the oncotype, the mamma print are used to perform adjuvant chemotherapy in low-risk patients or in high-risk patients, depending on the results of these signatures. And we are, with head and neck, I think we are still stuck, and we were thinking, like, of course, internationally, asking to the community which should be the way in which we move ahead with this data. Of course, what I have understood is that the trial is needed, and of course, what we are looking for is a methodology, or is a way, the simplest way to validate this approach in order to better stratify and to the patients for the next generation of trials. And we're asking ourselves which is the best way to use this, for example, external control to help us out. And with that, I would like really to thank you for the invitation, and I'm here for the questions. Happy to take questions. Thank you.
Thank you so much, Lisa. This was really a fascinating talk, taking us historically from few years back to where we are now. If I may give you my 2 cents, and then we'll open it to questions. I mean, I think there's so much data out there, and there's so much to decipher from. And the way I look at it is there's no escape from, and I'm glad you put that last slide, there's no escape from the clinical application, the patient, the clinical trial. And so I think no matter what we find, we have to test it in a clinical trial. What is the best population to test it in? I think you asked a very good question, which is, will this surpass the staging system as a predictive model, right? So this was really a fascinating question. And you know, to me, it seems like a low-hanging fruit really is the early stage disease. You mentioned the oncotype in breast cancer. This is where, for example, this data made a difference in breast cancer patients. And breast cancer is much bigger than head and neck, and there's much more advanced research. And so I think in head and neck, we have the opportunity to have to study those early stage cancers and look, for example, at exactly what you're saying, you know, the prognosis for T1, T2. We have the tissue on these patients. Let's look at these patients first. Let's not look, because the staging, if you look at the genomics, for example, for stage 3 and 4, it's very unlikely that the genomics will surpass the staging. If you have a patient with stage 4 cancer, they're gonna probably do, we know they're gonna do badly. Let's say locally advanced disease. So I don't think the genomics here will be as significant predictors as early stage disease. That's just my own thinking. But I don't know what you think about that.
Okay, so we are looking at the, so this BD2 DECIDE study was expressly on stage 3 and 4 patients, because I thought at that time the unmet need is there, it's not in the early stage. And so we are only, the data that I've shown you is on for example, if you look at the HPV data that are published now, you see that those patients were all stage 7th edition, stage 3 and 4. Mm-hmm. And according to the new edition, 1, 2, and 3. And the genomic is better than the stages I've seen you, as I've told you, in the HPV positive. Mm-hmm. What we have, and I've not shown you here, is another gene signature, which is made of 48 genes in oral cavity. And those patients, this is on 500 patients, both from the literature as in-house data. And what we are thinking is to launch a trial in this, this is OC, we call it OC48 because it's based on 48 genes. And the literally, this is in stage 3 and 4, right? Only stage 3 and 4, and these are really predicting the prognosis. But like the low risk are 80%, our outcome 80% versus the low risk is 35%, which is so high, the difference, that we wanted to, and this is the questions that I am asking all over, asking which is the study that I should do. It's, of course, this should be a randomized trial. The only thing today that I can propose is probably in oral cavity cancer, having a study with neoadjuvant chemotherapy in the high risk. The low risk will receive nothing because I cannot randomize patients. So I already have to to divide the low risk from the high risk, taking the study only for the high risk. Some of them will be treated with chemotherapy induction. At this point, I cannot put immunotherapy or whatever because it's too early. We don't have the data. And the other high-risk patients will not receive induction chemotherapy. And this probably is something that could be accepted.
Yeah, I mean, I don't disagree with that. I just think, however, that you're discarding the low risk easily. I think, for example, if you look at the oncotype is not perfect, okay? It predicts that, you know, for patients with low risk, you should be getting adjuvant therapy or not. But even when you look now at more recent data about omics, like radiomics and genomics signaling, you can see that you could even divide into the low risk category into even higher or lower. So, I mean, we struggle all the time, right? With early stage oral cavity, you treat them and then they relapse, or you treat them, you think they're good prognosis, and then you end up having relapse disease, or vice versa. So I think there's a lot to be said there. And even though you may not be able to do a randomized trial, I think maybe focusing efforts on predictive biomarkers with the data set that you have, or that we have, may be a good start for oropharynx early stage, for oral cavity early stage. I'm just doing the correlation with breast because this is exactly what happened in breast, and I think I see a similar story happening here.
What we are doing at this point is also to collect stage 1 and 2, because what I wanted to see is how was the distribution of these 6 clusters among the stages. So is it a disease that acquires a cluster 3? So we may expect the stage 4 has a lot of cluster 3, for example, because they are so bad. But this is something that we are looking at. So I may share this data with you in the next future.
Sure. I mean, this is going to be needing much more discussion. There was one question from Dr. Shin saying, have you have you done similar work in saliva gland cancers? Because, you know, I know you do a lot of work in saliva, but saliva has had some genomic analysis, of course, on its own, but have you?
It's mutational again. So here, no, because you do have mutations there, and also molecular alterations. For head and neck, we were really focusing on that because we knew that we could not go through that way.
Yes. So I don't see other questions. I want to really thank you so much, Lisa, for taking the time to give us a very excellent overview of this topic, which is very, very complex. I suspect, as you said, we will have to talk about it repeatedly in future meetings, and look forward to future discussions, and look forward to seeing you hopefully at ASCO and also ESMO. And thank you for all the attendees who participated. And I guess it is 8:30 almost, so we will adjourn and see you soon. Thanks.
Thank you. Thank you very much for the invitation. Ciao.